Welcome, everybody. I'm Mike Picard from Mass General Hospital, and my co-chair is Michael Main. I'm going to be the Mike, and he's going to be the Michael today. And he's from the Hartzler Group.
The Hartzler Group.
The Mid-America Heart Institute, right?
That's
Heart and Vascular
yes.
Institute, but not to be confused with the other Mid-America Cardiology. They're both in Kansas City. Welcome to the Value of Echo Summit. This is part two, and we're going to talk about transitioning from fee-to-service to value-based reimbursement, obviously a timely topic. We've got some great speakers. We're going to hear our first two presentations and then have some questions and answers on that session. And then we'll have three more speakers with questions at the end, and we'll have plenty of time for dialogue. Please use the app and type in some questions, send them up here. I'll be manning the computer, and we'll probably show some of those questions so you can actually vote, and we'll try to highlight some of the important questions that the audience has. So without further ado, I'm going to introduce Dr. Main, and he's going to then introduce our speaker.
Usually when somebody calls me Michael, I'm in some kind of trouble, so that's not usually great. Very pleased to introduce our first two speakers. They're actually ASE's legislative consultants. They work at the firm Mellman Castagnetti in Washington, D.C. They joined us about a year ago and have been doing great work for us. They're going to do a tag team presentation today. Pleased to introduce Lauren Aronson and Dean Rosen. Lauren and Dean, come on up. And I think we'll take some questions immediately after their presentation.
Yeah, thank you very much. Really appreciate the opportunity to be here, and we're thrilled to represent ASE in Washington at our firm, Mellman Castagnetti. Lauren and I are kind of from a...
It's going too fast.
It's going too fast. Our slides are moving on their own. Working a bipartisan firm, I've kind of spent my career working for members of Congress on the Republican side, and Lauren has spent her career on the Democratic side. But we wanted to kind of give you a bipartisan look at what's going on in Washington. I think we'll kind of start with just a quick overview.
God, the slides have their own.
Have their own mind. So really quickly, kind of describing the system that we are living in terms of an age of disruption, which I think we're seeing a lot. We were talking about technological advances and things that are giving rise to them. Lauren, you're not...
I know, I'm sorry. It keeps moving on its own. Is there a way to pause? Sorry, we're not talking. We defer to the other folks in the room who can help us. Yeah. I know, but it's going on its own. That's the challenge.
Okay.
So. I don't know. All right, that seems to be okay.
Okay.
All right, sorry.
That's all right.
Starting again. No, let's keep going. Is there a technology person who can help us?
Hey, the slides are just moving on their own, which is... Oh,
okay.
you're trying.
Okay.
We'll just talk. So really quickly, we can, just go through the first. I want to talk a little bit about Congress. So, what you've seen in business and other places is you have the world changing, where there's an entrenched system, little innovation, a public that's dissatisfied, and that leads to the rise of a controversial leader who changes the way things are done, and that is that describes companies like Uber and Lyft and other things, but it also describes the president and the way he operates. So we, in some ways, think about President Trump and changing a lot of the norms and the way that Washington has operated in the last few years, and some of that is substantively changing even Republicans' position on things like health care. Republicans always wanted to repeal the Affordable Care Act, but President Trump's talked a lot about drug pricing, for example. But on trade and immigration policy and other things, his agenda's been disruptive, and frankly, his approach. And again, we use disruptive terms. Sometimes those are positive, sometimes those are negative, but they certainly bring a lot of change. Uber is a great example. We're going to head to the airport today, and instead of taking a cab, which we would have done 5 years ago, we'll be in an Uber. Now we've got no slides.
No.
None up there.
Oh. They're working here, but now they're not showing. Yeah. There we go. Okay.
There we go. So look here. The good news for Republicans is, with all of the change, most of the president's term is left. And those of you who are Democrats in the room, I think the bar opens in about 30 minutes down at the Gaylord. But the fact is, it's changing the norms in Washington. And if you think about it, I'm going to attempt to move forward on the slide without going way forward. I'll let Lauren do it. Trump is kind of a reflection of the times and a reflection of the voters. And 5 of the last 6 elections that we've had to kind of navigate on behalf of ASE and others have been what the pollsters kind of call wave elections, where it's kind of flipped one party in to another party. And it's just that the fact is that people are very uncertain. The economic growth hasn't kept up. Wage stagnation for a number of individuals. Things like healthcare costs that we've all seen have grown faster than individuals' income. And that's led to a lot of dissatisfaction, which has given rise to this change in policy and in politics. And as Lauren will describe in a second, it's not just the public and not just the president, but we're seeing partisanship and division and change in Congress, too.
Thanks, Dean. So where we are now is that we have the 115th Congress, which has been unable to compromise on much so far. What's fascinating about this slide is that the yellow line is the number of party line votes in the House, and the green line is number of party line votes in the Senate. The House traditionally is a body that governs by majority, so it's very expected to see majority line votes in the House on a regular basis. What's unexpected and a new phenomenon is the number of party line votes in the Senate. That green line at the end of 2017 that spikes, the 115th Congress, is the number of party line votes that we see in the Senate. This is a very sad statement about the current state of the institution, the partisan, and even the tribal environment that we are now seeing in Washington. And why is that? Well, the middle has disappeared. In 1982, we had about 340 members of Congress that were considered to be in the middle of the ideological spectrum. In 1994, that number was around 250 members. 2002, a little over 130 members. 2012, we're down to 13. And in 2013, we're down to about 4. The other challenge as we think about how do we talk to members of Congress and the growing divide we're seeing in the institution is that we've had a number of changes in Congress over the last couple of years. So when you think back to when the Affordable Care Act became law in 2010, which was not that long ago, we only have now 44% of the House was there when the bill became a law. So you think about how much knowledge and the institutional knowledge itself that has drained from both the House and the Senate since that time. You constantly need to figure out ways to re-educate members of Congress on not only issues around the institution itself and how governing should work, thinking about complex foreign policy matters, but also from a health policy perspective, how complex healthcare policy is generally, thinking about Medicare and Medicaid and private health insurance and other issues. We need to constantly re-educate members of Congress on these vital issues, and it's very challenging when you're dealing with members who are very new to the institution. So turning to healthcare, where do we stand right now? 2017-2018 was 2 years of a lot of conversation about healthcare. There were some notable accomplishments and many failures. The Republicans in Congress attempted to repeal and replace the Affordable Care Act in 2017. For the better part of 2017, that was the primary goal of the administration and Republicans in Congress. As you all know, they were ultimately not successful for, I say, 3 key reasons. One, opposition is not a governing philosophy. It's entirely challenging to figure out what you want to do when you don't know what your strategy is, what your vision is. I think Republicans spent so much time focusing on their hatred of the law that they were unable to really see what they wanted to do moving forward. Did they just truly want to repeal it, or did they actually want to replace it? And if you want to replace it, what did they want to replace it with? And I think that a lot of Republicans in Congress very much felt like they were very surprised that Trump won and weren't actually expecting to have a real opportunity to replace the law. And as we know, healthcare is complicated. And so when you're trying to change 1/6 of the economy, you can't really do that on 6 weeks. It's very complex. And they spent a lot of time with fits and starts trying to figure out what the right solution was. The other challenge I think that they noted is that you can't just take away something from someone. No one would argue the Affordable Care Act is perfect, but when you're providing tax credits to people and insurance protections, you need to figure out what you're going to give them in return, and there was no cohesive vision or strategy from Republicans about how they were going about doing that. That said, Congress did do a number of healthcare major policy changes in 2017 and early in 2018. They did repeal the individual mandate as part of the tax law last year. They also delayed 3 of the Affordable Care Act taxes, the Cadillac tax, the health insurance tax, and the medical device tax. They also reauthorized the Children's Health Insurance Program for 10 years. That was part of the budget deal in February earlier this year. That was the first time that the Children's Health Insurance Program had a reauthorization of that long, and it truly was a bipartisan effort. In addition, in the February budget deal as well, there were a number of Medicare policy changes. Every couple of years in Congress, we see a major Medicare bill move forward. Usually, we had BBA of 97, we had MMA of 2003, we had MIPA in 2008, and then the Affordable Care Act. So we also then had MACRA, as you all know very well. And then this year we had the budget deal, which included a number of policy changes for Medicare extenders. It provided some donut relief for seniors in the Medicare Part D, and then also made a number of changes and improvements for individuals with chronic care, thinking about ways you can incorporate telehealth in the Medicare Advantage program, and so forth. Those last three items that I noted were done on a bipartisan basis, and what's very interesting to note is that the Medicare chronic care improvement process went through a very bipartisan process through the Senate Finance Committee. So when we think about hyperpartisanship and tribalism happening in Congress, there are elements of the institutions that are functioning. So the Finance Committee started this process about 3 years ago. They went through an open process with stakeholders. They had hearings. They asked for feedback and input. And ultimately what we saw was a package of policies, nothing that's going to necessarily change the trajectory, but it was bipartisan movement on issues that were important. So thinking about 2018 post the budget deal, what is Congress focusing on and what will be discussed? As you all know, the opioid crisis in this country is really dominating all of the news. It is dominating folks' conversation around the kitchen table, and members of Congress are very focused on it. We have nearly every committee of jurisdiction really focusing on elements of the problem. The challenge is that there's no one entity that can really figure out and coordinate from a federal perspective what are the right solutions and how do we make changes here. But we do have every member of Congress figuring out what bills they want to introduce and move forward. So in the last 2 weeks, the House has passed about 60 to 70 bills trying to focus on facets of the problem. The Senate Finance Committee has passed a bill bipartisanly, unanimously actually. Senate Help Committee has also passed legislation. So we're going to see this conversation and these policy discussions continue through the fall. It's also largely a political issue as well, as members of Congress are going home for the summer in August on the House side, and they really want to tell their constituents that they have made progress on this issue. The other healthcare policy issue that dominated a lot of conversation earlier this year was ACA market stability. So thinking about all the changes that had happened in the individual market and all the politics around the ACA, what are ways you could stabilize the program? So Senator Lamar Alexander from the great state of Tennessee and Senator Murray from Washington underwent a bipartisan effort for a better part of a year trying to figure out ways you could have bipartisan solutions to basically bring some stabilization to the individual market. Unfortunately, because of issues around the politics of abortion, they were not able to come to an agreement, and there's not been a stabilization package that has passed, neither the House nor Senate, which is partially contributing to why we have significant premiums coming out and all the news coming out right now for the fall. Congress and the administration are also spending a ton of time talking about drug pricing, 340B program oversight, and supply chain oversight as well, focusing on pharmacy benefit managers. I'm sure you all saw that the president has spent a lot of time talking about his blueprint to adjust prescription drug pricing. We've also had a number of hearings in Congress. We've had Secretary Azar testify before the Senate Help Committee last week. He's testifying before the Senate Finance Committee tomorrow. So this is an issue that members of Congress feel, I think, a ton of pressure from the administration to act on, and they're also seeing a lot of stories back home from constituents who are focusing on it. But again, kind of like the opioid epidemic, it's really challenging to figure out how do you address this issue because it's multifaceted. So we are seeing a ton of congressional interest in hearings, but we do not expect there to be large-scale legislation moving on drug pricing this year. Rather, the administration is going to be taking their own efforts and moving forward on either demos through CMS, and the FDA is going to be taking action as well. ACA market reform and repeal or replace are things that we're going to continue to have conversations about. There's a lot of pressure on congressional Republicans right now from conservative groups and former Senator Rick Santorum and others to revive the repeal and replace debate into August. So I think congressional Republicans are feeling pressure to have that conversation. Senator McConnell has stated he does not believe this is the appropriate time to have that conversation because there just isn't consensus in the Senate Republican conference on how to move forward. But there's no question that especially as we get closer to the election, we're going to hear more and more about that. And finally, on entitlement reform, That was something that was being discussed earlier this year. It was always a high priority for Speaker Paul Ryan, who is now going to be retiring at the end of the Congress. And particularly if you think about the Medicare Trust Fund report that came out last week that showed the Medicare Trust Fund was going to go broke 2 years earlier. This is a conversation that's not necessarily going to happen this year, but is something that's coming.
And as Lauren talked about, the Congress did pass earlier this year some of the Medicare, what they call extender policies. These are some of the things like rural hospital payments and other things that have to be reauthorized every couple of years. But the big change, particularly for the physician community and everyone else who's affected by Medicare, is that because the sustainable growth rate, SGR payments, were repealed a couple of years ago and replaced with MACRA, there's not this kind of annual big legislative Medicare kind of train that's moving every year that pulls everything else along, because physicians are no longer under the threat of facing 20 or 30 or 40% cuts in Medicare. So as a result of that, these other things have to get done that are getting done on a bipartisan basis. And because that was done earlier this year, there won't be another must-do kind of Medicare bill for another couple of years. So as that's happened, a lot of the focus has shifted to what's the administration going to do. And we now have our second Secretary of Health and Human Services, Tom Price, who is a physician, didn't last very long. The president's actually, I talked about some of the disruption earlier. There's been 6 cabinet members in President Trump's first 15 months that have left those positions. That's a high watermark. Going back to President Reagan, the highest before that was just 1 change in a cabinet position. So that's another example. But the interesting thing about Alex Azar is he's got government experience and he's got private sector experience. And this is somebody who knows what he's doing in many ways. He's helped run a big bureaucracy as part of the Bush administration. He's helped run a big company with Eli Lilly before he came. And he's, by all accounts, trying to march forward now. He's been in the job for just a few months and get things done. Lauren mentioned earlier the top priority of the administration has been drug affordability, but there's also some things they're doing in terms of legislation that's passed last year that they're implementing on the opioid epidemic, the Affordable Care Act. The Republican view and vision of the world is very different than the Democrat view of the world on health coverage. And so a lot of the activities within the bounds of the law that the administration is looking at is how do we provide more affordable options that are sort of outside of the traditional regulated marketplaces. So they've provided some more flexibility through a regulation they just finalized last week to allow groups of employers and individuals to pool across state lines in association health plans. They're looking at expanding the policy on what they call short-term limited duration policies that don't have to comply with all the ACA requirements. And most importantly and most relevant here, the Secretary has talked about moving in a very, very bold way toward more aggressive pay-for-value reforms, using the Centers for Medicare and Medicaid Innovation as one tool. Now, we haven't seen a lot yet from this administration. The Obama administration sort of theory, CMMI was very, very active, was let's kind of throw a bunch of spaghetti against the wall, let's see what works. And one of the criticisms was that there were some things that worked, but there wasn't a lot of evaluation done. We didn't really know which things were really driving change or saving costs. And the Trump administration to date, in part because of Tom Price, who I think was very ambivalent about value-based reforms, were really the opposite, did very little. So we've seen one value-based program, the BPCI Advanced program, continue, but to date, they've said they're going to do more. So stay tuned on this, and I think we'll see more. I know we've got a couple minutes, so let's just talk briefly about kind of the long view on healthcare. Where are we going? And I'm not going to spend time going through some of these issues, but when we think about, Lauren and I, kind of the 10 issues that Congress is either reacting to or is going to have to react to, it's technology-driven change and innovation. Things like the wonderful medical devices that are coming online and how those are changing treatment and reimbursement needs, genomics and diagnostics, new players and disruptors in the healthcare area, people like Teladoc that have 2 million visits as a telehealth provider in the country, primary care visits. And you saw, Lauren mentioned, one of the things that Congress did last year was provide some initial Medicare coverage for telehealth visits through the Medicare Advantage program. And these other things, I think we're marching toward value-based care. That's an area where there's bipartisanship. You can move ahead. We'll just skip to the end. Here's the thing about the parties and why a little bit of what Lauren and I have talked about not so much bipartisan, but almost sound bipolar, which is there's things that Congress is compromising on and trying to agree on, like how to attack the opioid crisis and moving to value-based care, and there's things where the administration's agenda is actually pretty consistent with that. In the near term, there's a lot of focus on affordability, but when you look longer term, particularly around issues of coverage, not value, not how do you improve the Medicare program where there's generally a lot of agreement, but where you look at where the parties are moving longer term, I'll just mention two things. One, Lauren said the Republicans really didn't know where they were going with healthcare repeal and replace. They knew they wanted to repeal, but they didn't know they wanted to replace. Now there seems to be a growing consensus, it's not unanimous among the Republican Party, that the further approach is what's embodied in a bill that Senator Lindsey Graham of South Carolina and others have introduced and are pushing. Bill Cassidy, a physician from Louisiana, is let's take all the subsidies in the current system and basically block grant them to the states, give the states a lot of flexibility to improve their own systems, and have them design their own systems and cap that growth at a rate that's slower than medical inflation. And so the way the Republicans are thinking about dealing with coverage and, frankly, costs is very different. The energy in the Democratic Party is really moving in a different direction. Instead of deregulating, capping growth, giving the states flexibility, it's, again, almost the opposite. There's 7 or 8 members of the United States Senate who are Democrats, who everybody in Washington knows. It's one of these open parlor secrets, wants to become president of the United States. It's probably among like 40 of them, but they say there's just 7. Well, all 7 of them, including some who ran in their initial race as moderates or more independent-minded, are supporters of Bernie Sanders' single-payer bill. And so if you look at that and you look at what's happening in the primaries across the country in this midterm election, a lot of the energy in the Democratic Party is around moving more people into a federal program, into Medicare, or even moving to a single-payer program. Now, those are really different philosophies. And so while we've got some balance in government, the Republicans have a slight margin, or the Democrats may win the House this time, you see that they're going to focus on things they agree on, like moving to value. But if we have one of these wave elections, maybe not the midterm, but the presidential next time, we could be moving in a very different direction, and wave election may be building here in the Senate. But why don't we, I think with that, we want to talk about the ASC priorities, and leave a couple minutes for Q&A.
So just to highlight a couple of issues that we are focusing on from an ASC perspective as we're thinking about our role here. Obviously, macro implementation is something we're keeping a very strong eye on. Congress is not yet at the point where they are willing to consider legislative changes to the program, even though there's obviously a conversation happening among providers. Obviously, MedPAC has also conveyed a very strong point of view as well. Right now, Congress has held 4 hearings on the issue. I think that conversation is going to continue to evolve over the next couple of years, but we do not expect wholesale change to macro at this point. Stark reform and self-referral is an issue where there is an incredible amount of bipartisan interest. Last week, CMS put out a request for information where they want to hear from stakeholders and providers about modifications that should be done to the self-referral law, specifically as it relates to alternative payment models and more flexibility there. There is also a lot of congressional interest. There's some legislation that is out there right now. We don't expect anything to move legislatively this year, but it's certain there is definitely a lot of interest here. And finally, site neutrality is also something that we are always monitoring. Obviously, everyone's well aware of the site neutrality changes that have happened over the last couple of years. I want to note that the President's blueprint on drug pricing does raise some questions about site neutrality. It's obviously not specific to ECHO, but the fact that that is something that site neutrality as a whole is a policy issue that the administration continues to look at, and there's interest on Capitol Hill on it as well. It's something that we're always going to be on alert for. So we'll pause there for questions.
Thank you.
Why don't you both have a seat? Sure. We'll go through some questions from the audience.
So first I have to say this was probably the most bipartisan discussion that one is going to see at a national level. So we've got, we've got 5 questions up here, Michael. And I think we've got maybe 1 minute per each question. We can get through all of them.
Let's do it.
Okay. So up to the first one, let me throw it to both of you, Dean and Lauren. When should my patients with congenital heart disease expect their coverage for their pre-existing condition to disappear?
I'm sorry, because you were talking that way, I actually couldn't hear you so well.
When should coverage, when do you expect the pre-existing condition coverage to disappear?
And this really is important for us as non-invasive cardiologists because we're diagnosing these patients with complex congenital heart disease.
So it's a great question, and I will say that wearing my Democratic hat here, and I'll be slightly partisan for a second, so not to disappoint you. I do think that we have Democrats in Congress, I think across the country, have grave concerns right now about what's happening in the administration. About 2 weeks ago, the Department of Justice chose to intercede in a Texas lawsuit, and the administration basically reversed the previous administration's decision and said that they are no longer going to defend the constitutionality of the Affordable Care Act, specifically the individual mandate, and secondly, the issues around community rating. So I think it's a little bit too soon to tell exactly what those changes will be, but depending on how that court case proceeds, we could be in a situation down the road where coverage for folks with pre-existing conditions is no longer something that we will have. Okay. So I agree it's an issue of grave concern.
We'll keep an eye out for that then.
Second question we have, I guess this could be a yes or no. Is Congress aware of the administrative costs in medicine?
Yes, but I believe that they think that they're too high. So it's something that we need to constantly educate them about as we're thinking about ways that we can better coordinate care and quality and provide high quality care for our patients. I think they look at, well, at least Democrats. I won't speak for Republicans. I think Democrats are always looking at administrative costs. We think about policies like medical loss ratio that we see on the health plan side. So I think they're always looking at the issue, and I think it's something we need to continue to educate them on.
I would say, I mean, we had a slide about the number of members who were here when the Affordable Care Act passed, and it's shockingly low to think about a policy that wasn't enacted that long ago. This year, we're nearing a record number of members have already announced their retirement in the House and the Senate, including a lot of committee chairmen on key committees that we focus on. And so other than the career staff at the Centers for Medicare and Medicaid Services, the question is a good one because it underscores the fact that we really continually need to educate folks. They often come up with these assumptions about, you know, here's how much time you should be spending, here's the value of the administrative time, can't you get more efficient every single year over time? And that obviously isn't always the case. So I think Lauren's exactly right. I think there's an understanding, but people want the majority of care to go, or cost to go to patient care. And so we've got to educate them as to what the reality is in terms of delivering that care.
Next question. So Medicare Part A, by some, is projected to become insolvent in 2026. And when will that dialogue start? And how is that going to motivate some of these changes?
It's a great question. So if you think back to the way Congress has played out the issues around the SGR, I would love to say that Congress is thinking about it now. Unfortunately, the answer to that is they are not. I think it's largely exacerbated by the fact that they're part of the reason why the trust fund's going insolvent 2 years earlier is because of a lack of revenue going to the Treasury because of the tax law. So Democrats are particularly concerned about having a conversation about entitlement reform when we need to have one because of the tax law changes. So I think there are many folks in Congress who would agree that we need to have that conversation for other reasons, but the politics around the way the tax law went into effect and everything in the fall is really complicating that discussion. I also think that members can just not think that far ahead, to be honest. Getting them to think about policy issues right now is challenging. You think about all the fits and starts we had on SGR patches. I can remember back to a time when I worked for the Ways and Means Committee, and I think in the span of 5 or 6 months, we had 4 or 5, patches for SGR that were only a few weeks at a time. That's not a way to govern, but I do think the short answer is I don't think Congress is going to be looking at it until probably a year or two before.
And the reality is that it was not a surprise to any member of Congress to know that the trust fund is running out of money, whether it's 5 or 6 years from now. We've got, $1 trillion deficits and debt as far as the eye can see. But the issue is, frankly, that it's a difficult thing to do because what do? You either cut providers, reduce benefits, or raise taxes. And those are 3 things that Congress doesn't like to do unless it absolutely has to. But it is a reason that I think we're coming back to this cost debate. And maybe one thing that we would sort of leave you with is a lot of what's driving the Republican view on let's block grant and cap it, the spending, and a lot of what's driving the Democrats' view on let's move everybody into a government-run program is not just driven by coverage, but driven by this growing kind of cost conundrum. So it'll put a lot of pressure on this specialty and others in the future.
Great. So we're going to end with I have one last question for both of you. I want a really short answer. So if I were to go home tomorrow and call my representative, as a member of the ASC, what is it that I should be talking to them about? One brief soundbite.
I would start by educating on what ASC is and what we do and the value we provide to our patients. I can't underscore enough how members of Congress are young. So much are trying to digest and dealing with their day-to-day as being a member of Congress. I would start by educating them about what we do and the role we play for our patients.
And I would just add, I think the key thing, if you look at the topic of this conversation and others is this move to greater value, looking at things from a systemic way, looking at how to take care of the whole patient, looking at coordinating care across specialties as well as primary care. And so I think the only other thing I'd add to what Lauren said is talk to them about the critical role that you play, not just when you see the patient for that one treatment, but how that treatment, that diagnosis, that care fits into the whole care of the patient, and how that patient is going to be improved by that in terms of their overall health.
Great. Well, thank you very much.
All right. Our next speaker is known to many of you, nationally known in the area of practice management. Pleased to introduce Kathy Biga from the Amitabh Heart and Vascular Institute in Chicago, Illinois. Kathy.
Hey, thank you very much. I think that was a great overview of the Affordable Care Act, and now we're going to kind of launch into the specifics of MACRA that was referred to. And I want to make sure that we keep in mind that that the Affordable Care Act has been on a lot of discussion up in Washington, whereas MACRA really is not going anywhere anytime soon. And I think it's one of those. No, these are the wrong slides.
I think we still have the first slide set up.
So, whereas I don't think QPP, which is what MACRA is now known as, is going anywhere. So that's what we're going to lay out here and kind of walk through things pretty quickly. And trying to put it into your context as echocardiographers in the cath lab. So no discussions, in the echo lab. And I'll try to go through these quickly because I know we're a little bit behind time. So I want to draw your picture. Remember, the Affordable Care Act was passed in 2010. Then there was something that came out of Health and Human Service, which is where it really governs most of us are up in Washington, and that was the HHS mandate. And I only included 2016 and 2018 on the slide because normally when I do this talk, we talk about how we were never going to hit these goals by the end of 2018. And so now here we are about halfway through 2018. How many think that 50% of our Medicare beneficiaries are already in an alternative payment model? What do you think? About 3 people. And the reality is that with the Bundle Payment Initiative, BPCI Advance, we are almost at that level already. So by the end of this year, 50% of your patients will be in an alternative payment model. And as we've been talking about, we're moving very slowly according to where the government really needs us to move. So even though our bundled payments, our mandatory bundle payments were canceled, pay attention the next couple of months because we do think it's going to come very rapidly. The lighter blue circle from the Health and Human Service mandate stated that 90% of all of our CPT codes that we bill will be tied to quality, and of course they are because of all the stuff we're doing with PQRS. Now going to the right-hand side of the slide, then MACRA came along in 2015, a bipartisan approval, and MACRA, which is now called QPP for Quality Payment Programs, not to confuse you with a million acronyms, but MACRA is no longer there because CHIPS was embedded in that for the kids. Now we have 2 arms, MIPS and alternative payment arms. Most of the physicians in this room are going to be in the MIPS arm, which is the merit improvement. And that's a little bit about what we're going to talk about today. We used to be, just 2 years ago, in meaningful use. How meaningful is your EMR? We won't vote on that right now. PQRS, those clicks that you do in your practice that relate to quality. And then my guess is how many in this room have ever heard of the QRUR report? Great, 3 of you, maybe 4 of you. So when you go home on Monday, this is one of the things that you need to do. In addition to calling your person up in Congress, you want to find your QRUR report because it is the infrastructure that every single physician and APP has in their practice that is both the quality and the financial component. It combines our old quality programs into the new component of MIPS. So we lovingly refer to that as MIPS. It is a quality cost improvement activity as we kind of go through this. And then our alternative payment models, which I'm not going to spend a lot of time on, but we'll do very quickly. So MACRA, which is now QPP, which changed its name in 2017, eliminated the SGR. We heard that. We heard it was a great idea. We no longer have to worry about the cliff, but trust me, we have a whole lot more to worry about in MIPS than we really did in the SGR component because it's not going to go away. It has both a penalty and a bonus component. It is self-neutralizing. We are in that year right now. 2017 was our first year of data that was collected. Our penalties or our bonus will start January 1st of 2019. Not insignificant, I might add, and we'll talk about what those penalties will actually be. Alternative payment models. How many in here are in an alternative payment model? Medicare Shared Savings Plan, Next Gen. Just a few. My guess is you're probably not in a qualifying alternative payment model, so that's why we're going to concentrate on QPP as it relates to MIPS specifically, because that's where most of our physicians are at. Your 2017 data, too late. It's already done. Actually, our report card and our scores will be out within the next 2 weeks. So the temporary scores are out if you're interested. My day job is with 60 cardiologists in Chicago. One of my groups scored 100. We're very proud of that. My other group scored about 97. The initial data coming out is that most people scored below 50 points, so it is something that you all have to pay attention to. And my guess is if you go back on Monday and ask your administrator what your score was, many of them don't know. Your score for 2017 was divided into 3 categories. It was divided into quality, which you're all familiar with, advancing care information, which is our EMR and our meaningful use, and improvement activities, different things you can do to improve your patient care within your practice. Cost was not scored last year. We did not think it was going to be scored for a while, but surprise, it's here right now. So we are almost 6 months into it. Your cost will be scored this year, and it will count in 2020. So 2018 will be in 2020. In order to allow for some cost allocation, they decreased quality. So quality is no longer worth 60 points, it's worth 50 points. Cost is worth 10 points, improvement activity is worth 15 points, and meaningful use is 25 points. Every physician in APP in this room will have a score that will be publicly reported. So in 2019, when that score gets reported, chances are you did it as part of a group. So chances are you did not do it individually, so keep that in mind. I want to talk for just a second about QRUR. Number one, so when you leave here today and you go to another lecture and somebody says, did you ever hear about the QRUR? You can raise your hand and say, yes, I do. So it's a roadmap for MIPS. It has a lot of your data in there that can help you get ready for MIPS. It will also identify 2 of our 3 cost components, very important for non-invasive cardiology. The third component, which is based on episodes, and we heard a lot about how our Secretary of Health and Human Service is very interested in episodes. Episodes are coming back in one way, shape, form, or another. And the third component of cost, which is episodes, is now available. It also will have your quality scores and stuff. I want to show you what that cost report looks like. This is for outpatient PCI, and even though most of you are non-invasive physicians, I wanted to draw your attention to the third from the bottom. It says non-invasive cardiac testing. It highlights the amount of data that we have as it relates to cost in your particular field. As we continue to look at that continuum of care for our patients, this type of data is available to us both on a practice level, and this cost data is available to us on an individual practitioner level. So if you've not been able to get it, and it's not easy to get, so I won't pretend that it's easy to get, but you can see Dr. Rose. He'll help you find it because he knows exactly where to find it. But this happens to be one of our field test reports for outpatient PCI. The other episode that is going to be utilized is our STEMI with MI. And if you happen to do a lot of peripheral vascular in your program, lower extremity revascularization. So those will be our 3 main bundles. They'll be adding CABG in another year. This is what the QRUR report card looks like. You want to be in that upper right-hand quadrant, which is low cost, high quality. You can see this particular practice is right in the median. They will not get penalized. You fall over into that lower quadrant and you will get penalized. The penalty for 2017 data is 4%. The penalty for this year's data is 5%, and it continues to escalate. So not that it's an insignificant amount of money. In your QRUR, you can see the cost reports in there. Your practice gets attributed some patients. We don't have time to go into attribution, besides your heads would spin if we talked about it, but it will become a very important concept. We're actually going to patient attribution with patient-reported outcome measures starting next year, so it's coming quickly. And then our Medicare spend. Our Medicare spend is those patients that in your practice you either did the procedure or you did 30% of the E&M codes, and then your practice owns that patient for the Medicare spend. You can actually see what that data looks like on your QRUR report. The other thing I wanted to have you take home, so you have 2 homework assignments today. One is to find your QRUR. The other is to know what your risk score is. Risk scoring is becoming extremely important in this day and age, and it's also highlighted for your group. Now again, if you're in a multi-specialty group or an academic group, you have to take that into consideration when you're looking at your risk score. But you'll see this happens to be my risk percentile. We were in the 78th percentile a couple of years ago. We worked very hard with our physicians to raise our risk score, and we got to the 84th percentile in just a year, which is really a significant improvement. So how did we do that? Well, we did it by understanding what risk adjustment was. Every single one of your patients has a risk score. They get that risk score in a calendar year. This is something that you probably haven't really been educated to because it never really was terribly important. The Medicare Advantage plan started risk adjustment. They learned that when they came into our practices and asked for 100 charts at a time, that they could actually go through that chart, find all kinds of comorbidities, and end up being able to score those patients higher and get paid more. We need to translate that now into our offices. How many of you get chased around the hospital by ClinDoc individuals that want you to make sure you're specific in your code? Sound familiar? Okay, so hang on. We're going to have that in the office as well, too. So a couple really quick slides on how you can do that. Number one, after you find your QRUR report on Monday, you are never going to bill an unspecified code again. Promise? Because that is the killer of your risk score. The second thing that you're going to do is you're going to give us as many diagnoses as you possibly can for either that echo that you're reading and or for your office visit, primarily for your office visit. The more ICD-10 codes you can give me, the better your risk score will be. Why? Because it will show you how sick your patient is, and that's how Medicare will know how sick their patient is. You can very easily do two things. Now you have 3 homework assignments. The third thing you can do is ask your billing people to give you a report on your top 5 diagnoses. If hyperlipidemia and essential hypertension are the top 2, we'll have to shoot you. Okay, so you don't want that. So have them do that. Also make sure your billing system is open, that you can bill as many codes as you possibly can. Make sure you bill for that full list of codes. And then there's methodologies in all of your EMRs that you probably are totally unaware of, but I know we're also running tight on time, so I won't go into the hierarchical coding. But look in your diagnostic template. You'll either find red H's or you'll see an HCC, Epic has it in blue. You will find ICD-10 codes that will tie directly to these hierarchical codes that will give you a much better picture of risk scoring. This is just an example of what that report card looks like when we first started. You can see our average number of diagnoses sat right around 3. We're now up to about 4.5 diagnoses per patient, another reason why our risk score went up quite a bit. Make sure you use your entire team. Team-based care, the redesign of team-based care is very, very important. Making sure that you utilize your front staff as they're bringing patients into your practice. Make sure you use your APPs. We always use our APPs whenever we can in that first visit, because in order to get your risk scores up, you have to document it once a year. So in that first quarter of the year, we use our APPs to really help us ensure that we get those risk scores up. And I think these slides are available for you so you can take them home. This is the one slide you can take to your next practice meeting. It gives you the nuts and bolts of hierarchical coding 101. It tells you exactly what you need to do and the fact that you have to have a record of choice, so it has to be identified at least once per year. If you're in a multi-specialty tax ID, you share an EMR, this makes it a little bit easier. If you're independent practice, maybe not quite so much. So I'm going to go really quickly through the MIPS components, specifically as it relates to our non-invasive cardiologist. In the Echo Lab, as we mentioned, most of you are probably reporting by group. I did put up one of the measures that are very specific to Echo. My guess is that most of you don't use this measure because it's not one of the popular measures that are easy to gather. If you don't know what measures, how many of you know what 6 measures were reported on you last year? Yeah, like 3. You can go, if you get bored later today, go on Physician Compare, put your name in and your zip code number. It will tell you what your quality metrics are. My guess is that you'll have colonoscopy listed on there and influenza listed on there because your hospital is probably doing population health measures. So that's probably what you have as you kind of go in there. But the world is changing. We are going to continue to separate different types of quality metrics, and ASC will be working, I'm sure, on identifying those that are specific to ASC and moving those along. In your QRUR report, it will actually show you what your scores look like, so that's an example of what you look like. Here's the takeaway message in here, is to make sure that you're using the national benchmarks because they change every year. If you're only looking at your internal benchmarking, it's not going to help you as much because you're going to be scored to everybody else who used that measure. So if you're doing ACEs and ARBs, you've got to look at it across the country, and these benchmarks are released every year. So make sure that you're internally looking at your report cards and what that looks like. Second part of MIPS is advancing care information, which is obviously our meaningful use, one of our more complicated measures to look at, but nonetheless worth 25 scores and probably not changing. That's pretty much all I'll say about it. Unless you have some questions, I'll be sticking around later, and you can certainly let me know. This is just an example of a report card. We do report cards for both quality and advancing care information. Our physicians get them every month. Remember, in advancing care information now, it's all about numerator and denominator. So if you felt really proud that you got one electronic secure message to your patient, because that's all that was required 2 years ago, that's not going to work anymore. Now we need all those email addresses, and yes, we do need to electronically communicate with our 90-year-olds. Somehow, some way, we need to do that. So this just tells you that it is all about the numerators and denominators component. And then cost, as we talked about, really kind of the big elephant in the room. We're waiting for the rule to come out in July. We assume that it is going to change. Cost could be as high as 30% starting next year. It may stay at 10%, but again, as you heard from our prior speakers, cost is a huge issue, so they're probably going to push us and accelerate it a little bit, and most probably will add those episodes. We know that the 8 episodes that I talked to you about, the outpatient PCI, STEMI with PCI and lower extremity revascularization, will in fact be in 2019, and CABG will be added in 2020. This is what your data looks like, looking at both your per capita costs and your Medicare spend. Those are your other two cost components that are on your QRUR. I'll also tell you that you might want to look at another one more acronym, and then I'll let you go so that your eyes don't glaze over, and that's the supplemental QRUR report, which actually looks at your episodes within your tax ID. You can see there on the third column the risk score. So this starts to help you understand as a group of interventional cardiologists what that looks like. You'll also find it for heart failure and a number of others. This no longer is given to us. They now have gone to those field-tested episodes that I showed you earlier on the outpatient PCI. But it's a way to understand the amount of data that's out there on us that really becomes very, very important as we kind of go through this. And then last but not least, this is the new category, not one that we had before in our prior quality programs, and that's the improvement activities. It didn't replace anything, so it is the new kid on the block. It's worth 15% of your scores. The good news right now is you need to hug one of your fellow providers because only one NPI can do this activity and the whole group gets credit for it. So I'm willing to bet, since hardly any of you know what your quality measures are, you probably have no idea what your improvement activity measures were. But pay attention, because they have said that eventually improvement activity will be by provider. So even though we're following the coattails of some of our physicians that are doing this for us in the future, each of us will have to do these improvement activity components. And they're good for 90 days. They did change the rules for this year. Quality is a full year of reporting, not 90 days. Cost is a full year of reporting. Improvement activities and meaningful use is 90 days of reporting. Just some examples that I thought would work for in the Echo Lab, just in case you were interested. You can always look at them. Anticoagulation, population health, some of the things that are kind of very specific to the patient population that you tend to see day in and day out. And then I'll fly really quick, because I can't quite tell just how much time, make sure we have time for other speakers, is the alternative payment models. And there's just a couple of key points that I want to make sure you understand about alternative payment models, that second arm of QPP. Why do physicians want to be in alternative payment models? Because you don't get penalized. You get up to 5% bonus on your entire Medicare fee schedule. So it's why many of us were struggling and trying to get into approved alternative payment models. But when the rules came out, that proved very difficult. The only ones right now here and today that are approved alternative payment models are Track 1 Plus, which is brand new this year, Medicare Shared Savings Track 2 and Track 3. And then I was on a conference call just about a half hour ago for BPCI Advance. BPCI Advance has been considered now an alternative payment model. As you know, it was a very rapid introduction. Word was released in February. We had to let them know by March 2nd if we were interested, and now we have to commit by August 1st. So very, very short timelines. But the good news for physicians, if you hit the qualifying elements, you could end up being an alternative payment model, which of course would be that 5%. Most of us are in non-qualifying alternative payment models, meaning that we don't meet the requirements. So therefore, you have to do both MIPS and the alternative payment model. And that will come mostly Medicare Shared Savings Track 1 is the one that most of you are probably familiar with for Track 1. And in that way, you have to meet both of those. I like this example, the little man down there on the right who couldn't figure out if he was blue or green. Well, that's what most of us are. They tend to be a provider that is both in an alternative payment model and MIPS. You can see there's many providers that are in non-approved or non-advanced alternative payment models. Those are the blue guys. And I won't go into it. There's a lot more rules, but your eyes will glaze over if we did it. So just to let you go home with a couple of things, make sure that you're QPP ready. It's not going away. Affordable Care Act may change as the world evolves, but it's not going to go away. It has to be physician-led, in my opinion. The reason we have been so successful, both in our ACO and in our QPP implementation, is because we have a physician-led practice, and you have to know where to find your data. You really have to go and figure out where your data is at so you can use that as a roadmap, because the bottom line of all of this is to start to reduce that unwanted variation in care and really being able to understand our cost and how important your documentation is. Very, very important. So with that, thank you very much.
Great. Thank you. So as I said, we're going to have time for questions after the last two speakers. So please type in your questions, and then we'll collate them and throw them out to the whole group. So Ms. Biga spoke about the importance of physicians leading this charge, and our next speaker is one of those physician leaders. Jeff Rose is one of the leaders of the cardiology practice at the Sanger Heart and Vascular Institute in Charlotte, North Carolina. And he's going to speak on strategies to reduce low value care.
Thanks, Mike. Skipped a couple of slides because I tried to get us back on time so we've got time for questions. So, again, we just heard how impossibly complex these mechanisms are. Most of us are in MIPS. We need to know about our QRUR reports. We want to get into alternative payment models, a lot of strategies that we have to go through to get there. The question is, again, what's driving this? A couple of slides from last year just to update and just to orient. So, the problem here, of course, is Medicare is running out of money. On the left side is what Medicare looked like when it was designed, right, back in the, 1965. That's a slide from 1970, just in terms of the population. It's 58 million now. It's going to 82 million by 2030. If you look at how much we're spending on this, it's 588 billion. Actuarially, it's going to 1.16 trillion. There's nothing we can do about that. It's 50%. When you look at what we're spending on Social Security, Medicare, Medicaid, it's 50% of your tax dollars. So that's the challenge that we have. And then how does this come home to roost? When we look at it, on the left is the number of Medicare beneficiaries, again, actuarial issue. On the right, you can see that when we started with Medicare, we had 4.6 workers per beneficiary. We're now 3.2. In 2030, we go to 2.3. Okay, so that's just the math that we're up against, and we talked about this in the previous talks. So last year when I showed this slide, the number instead of 2026 was 2028. Okay, so the revenues that are coming in out of our paychecks to pay for Medicare, that's what pays for the in-hospital part A, that goes bankrupt in 2026, which means then that payroll taxes coming in pay 87 cents on the dollar, which means that your hospital service line takes a 13% haircut on all the Medicare business, unless we increase taxes. Okay, so that's what we're up against. Congress is not going to take this on because it's political suicide. But your hospital's already doing 5- and 10-year business planning revenue cycles, right? So these are the realities, and if we think that this isn't going to impact us, we're kidding ourselves. If you look from the advisory board, this is sort of their playbook back to system CEOs. What they tell you is, obviously, the system's unsustainable and there's no legislative solution. Number two, your systems need to grow. But it's not just bigger is better. They have to become integrated. They have to be delivery networks. There has to be this new verb or noun of systemness, right? We have to get the value of aggregation, not just a big collection of assets. And then the third issue here is we need radical cost reduction. And we'll talk about that a little bit. Not just more widgets per time, not to have our sonographers do, 15 studies a day instead of 8, but how are we actually going to reduce net cost by being more efficient? So the blueprint for doing this is an article, and I would encourage you to look this up. It's a short article in JAMA from 2007. Porter from Harvard Business School is an academic. Teisberg is an engineer. And they both came up with this concept over 10 years ago about the way to solve this is we've got to begin to create systems that create value. Not that just compete your system against the system across town, your group against the other group, but we actually have to treat this like any other business and create value back to the customer. And it has to be provider-led. It cannot be administratively led. And when I talk with colleagues, that always seems to be the big frustration, is that the people who are empowered to make the decisions don't really understand the product and the customer. So as we're doing this, we have to organize our care around conditions, and we actually have to measure things and get better like every other industry does. So what is value? We throw it around the term all the time. What is value? Health outcomes per dollar spent. There's the quick and easy thing. What are you getting and what are you paying for it? And we'll summarize it as V equals Q over R. Value equals quality divided by the resources. If you break that down, when we talk about quality, and we just had a whole session on that, but there's really 6 elements from the Institute of Medicine. It's got to be safe, it's got to be effective, it's got to be efficient, it needs to be equitable, patient-centered, and timely. So the things that you're doing in your practices and in your labs have to be geared around those types of elements. We have to organize, deliver, and measure, and then improve upon, just like every other field does, around those things if we're having a conversation about quality. But what about the denominator? What about the resources that go into it? And this is a particular sticking point, because Kathy just told us that we're going to be evaluated on cost. We're actually not being evaluated on cost, we're being evaluated on charges, right? Because the payer is looking at it, how much did I charge them for what I did? So how expensive am I? And that's important, okay? But the other side of this is how much are you actually spending internally to deliver the things that you're doing, right? And most of us have horrible internal cost accounting systems. But at the end of the day, that's actually what matters. That's the dollars going out the door. How a payer indexes and scorecards us is relevant and important. But at the end of the day, in terms of delivering health care, you need to know this, right? Because revenue is virtual. It can go away. Your patient can't pay. An insurer cancels a contract. The insurer makes it. But your costs are real. Unless you're going to liberate yourself of overhead or staff or something else, your costs are very, very real. So to begin to tackle that, we have to look at variation, because variation equals cost. So when we talk about low-value care, the slides I just went through, the Medicare report to Congress, the things that are important this year, the same report that told us we're going bankrupt in 2026, has a whole list of recommendations about low-value care. The top 4 are really about just restricting payment. Let's just put more gates up there. Let's make more prior authorization. Let's shift costs and make higher copays and all that. It doesn't make things any better. That's just cost shifting. But 2 promising things that are in there, and again, how this will be implemented, who knows, but decision support tools. How can we make better decisions, not do the things we don't need to do at the point of care? Also, how do we link cost and clinical effectiveness to payment? So those are the things that we want to focus on. So if we just want to go very quickly into what are the must-dos, not 10 things, but what are the absolute must-dos, right? So don't do things you shouldn't be doing. Even if it's reimbursed today, find something else to do, because the music's going to stop and there's not going to be a chair to sit on. So we have to start getting away from the things that we know every day we're doing just because. We have to stop doing those things. Choosing wisely is a good place to start. These are, if you go to the website, these are the things. These are self-evident, things you shouldn't do. Don't do a TEE to look for source of embolism in something you're in a patient. You're not going to do anything differently anyway, right? I'm guilty. I do that every day, right? Okay. We have to put systems in place to stop doing these things just because. Okay. A shout out to Mike's group and Dr. Flutterman. This is an abstract that's here at this meeting. So this is a practice that was put in place using the Epic system, an EMR alert to the providers if they ordered an echo, and there had been an echo in the last 6 months. Because guess what? Most hospitalists aren't looking back to see if there was an echo done in the last 6 months. Here's an alert, okay? That canceled a bunch of studies, but then people realized, well, yeah, I actually need it. But 20% of the time, it canceled the echo. That saved about 4 echoes a day. That's 1,000 echoes a year at this one place, if this were systematically embedded. Okay? Brilliant abstract, brilliant thing. We all should be doing things like this, and we have to create a structure and a culture that this is what we're doing, not as something extra, but really just as the work. Clinical pathways are sort of the next area. We've got to come up with standard ways of doing things. Here's an example from our institution. 2 hospitals. One's the 1,000-bed hospital, the other's the 250-bed hospital. The 1,000-bed hospital, we have a protocol that we built with the emergency department, with the hospitalists, and with cardiology that said, these are the patients in the emergency rooms who are low risk, they can go home. They don't need anything else, they can go home, we'll see them as outpatients, et cetera. Okay? So with that, on the weekend, which is the tension time, because this is when we're paying for staff to come in and do studies and so forth, right? 7% of all the echoes we're going to do on a weekend are a stress echo. Positive stress test rate is about 8%. Okay. Hospital B, where we don't have the protocol, we actually, 30% of our echoes are stress echoes. Okay, at that hospital, 2% positive rate. Okay, we're doing double the stress echoes in a hospital that's 4 times smaller because we're not using a protocol that we have. And we have this protocol and it's online and I can share it with anybody who wants it, but the point is we have to start doing these things because what's the consequence at that hospital where we're doing those stress echoes? We have the cost of our staff. We have the cost, the bed opportunity in the emergency room. It's somebody sitting in there and we've got patients waiting outside and that person sitting there waiting until we can get to them to do the echo that they don't need. We're staffing that unit, we're transporting that patient, and we're burning out our staff. So now our staff are going to turn over and now, and this is the consequence of our inaction with that kind of variability. These are the types of things that we have to have a conversation around and organize our work around this. A couple quick words, change management. Google John Cotter, okay, because all of this is really about change management. It's taking about the stuff that's embedded that we do every day and doing something different. You have to have clinical champions. You have to have buy-in of the stakeholders. The protocol I just talked about won't work. Where it is working is because we've got buy-in of the ED and the hospitalists. If we didn't have them on board, it's just another thing that we're telling people to do rather than having them own this as well. And then you just have to repeat those cycles. You've got to share the early wins. So just, wrapping up a couple of quick things to think about, right? Our clinical service is all cardiologists who are in the echo lab, right? Should we be giving them handheld echoes, right? Should they be doing, in the patients that they're seeing who have had the full echo, who needs a limited echo the next day, pericardial effusion, should they just be doing it themselves? Not billing for it, making it part of the clinical exam, can archive it and so forth. In a big hospital, if you have 6 or 8 such of those things, you've just freed up a machine and a sonographer to do needed outpatient studies if you've got access issues. These are the things we need to think about, because guess how much money the institution makes for that limited echo under the DRG? 0. Okay? You got 100% of the cost and 0 return for that study. So we have to be thinking about novel ways to do this. Following Dr. Main's example, should we be doing things where we automatically offer limited echoes in someone who's had an echo within 3 months? Same way the flag came up. These are the things that we have to think about how we can do things better. So again, for high value, you have to have expertise, technically and professional. You've got to provide the service in a timely manner, and it's got to be reliable. You've got to have QA processes in place. If you're not doing these 3 things, you're not going to be able to offer high-value care, and it's incumbent upon us. We have almost 330 million in the United States. About 50% of our population can't afford something that they need. We're the richest nation in the history of history, and 50% of people who need our product can't afford it. We've got to figure out a different way because a solution will be coming, and we probably won't like it. So this is our time to start beginning to think about it and talking about solutions. So I'll stop there, and thank you very much.
Thanks, Jeff. Great talk. Irene Butler wanted me to mention that all of these talks from both sides of the Value Summit will be available online within the next few days, too. So a lot of information in these. Be expecting those to be available very soon. Our final speaker today is well known to all of you. Sharif Naga from Houston Methodist will be speaking on the Image Guide Echo Registry, which he basically did a ton of work on, and that is now up and running. We look forward to hearing about it.
So what do I use to point? Right here. Okay. Take that out right here.
And again, while we're waiting, if you have any questions, please jot them down in the app. We'll post them, and then we'll have about 10 minutes for Q&A at the end of Sharif's talk.
Thank you. That's okay. Okay. So some of the material I will present, you have heard it, and we can go fast through it since you've heard from it from the previous speakers with respect to MIPS and adjustments of payments. I will take you through the idea of the Image Guide registries and particularly the Image Guide Echo Registry. So the ACC assembled a task force a few years ago looking at the idea of imaging registries. It was recognized that many of the practices in cardiology have their own registries to look at quality, but this is an issue that was not satisfactorily addressed by imaging. And that task force had a number of recommendations, including the need for standardized reporting and definitions, the use of appropriate use, the implementation of appropriate use criteria, research in the imaging field relating imaging with outcomes, as well as the creating of registries. These were the thoughts about what an ideal registry would look like. Ideally, it would be a multi-center imaging registry. It would explore the development of a national imaging registry that allows for multimodality and multi-speciality participation, so physicians who read in several of the echocardiography, say, and nuclear and CMR and so on, would use that registry for all of these purposes, and then investigate incentives that can maximize participation in these cardiovascular imaging registries. As you've heard, there are several incentives that Congress has agreed upon. So why are registries important? One, you would get clinical data from patients in a raw form. All the information pertinent to a particular patient will be captured, who goes, say, through an echocardiogram, and this will give the field the opportunity to look at this data and later on use it for research purposes. Practices and physicians can readily view their work product and then use this to implement informed decisions as well as improve their quality performances. National marks can be developed, and similar practices can link to aggregate data for benefit of seeing patient care platforms from larger practices or from practices similar to them and see how they stand at a national level. The Image Guide Registry was launched by the American Society of Nuclear Cardiology in 2015. ASE joined as a registry partner in 2017. As it stands, the Image Guide Registry is the first cardiovascular registry of its kind, and it focuses on SPECT, PET, echo imaging studies. Down the line, we anticipate there will be other partners for other imaging modalities. The primary purpose is to provide a fully integrated platform to seamlessly collect data for these types of imaging modalities and then assess quality, safety, and efficiency. It has two modules, so if someone goes to the Image Guide Registry, you have two modules, one for ASMIC and one for ASE. If I'm a physician who reads echocardiography only, I will go to the ASE portal. What are the data that the registry is collecting? So there are site-specific data that I'm not showing on this slide, more of administrative aspects to the lab, the size of the lab, sonographers, physicians, their certification, both with respect to sonographers and physicians. But then with respect to the specific studies, this is the info that will be obtained, and they are present in virtually almost all echocardiography reports. demographics, clinical indications, determining appropriate use criteria met or not, the views obtained, data on ventricular size and function, also atrial size, 2 comments on the valve, one with respect to the valve structure and the other with respect to the valve function. If there are comments on pericardium and diastology, they will be captured as well. And any quantitative measurements that the lab has done will also be available in the registry. By the way, a lot of the data that is captured also follows ICAL standards. These are the goals of the ECHO module. 1, providing timely quality of care feedback for the echocardiography physicians, facilitate the fulfillment of regulatory and other reporting requirements, inform health policy and reimbursement advocacy, serves as a platform for research and education, drive the field of echo by demonstrating the value of technology and opportunities for improvement and expansion, for example, how frequently the use of 3D echo in specific situations, how the use of strain is in specific situations where it can impact the treatment plans. It certainly allows the physician community to look at this data and utilize it, and so shape the field and maintain control of their own data. Would be able to link with outcomes data to trace the patient along the continuum of care, and as we're looking at this down the line, also include ultrasound images. And now we can look at the report with the images, and that opens a lot of opportunities for research, for accreditation, and other topics. These are the phases that are present for the implementation of the registry. Phase 1 is completed. It dealt with the site profile, demographics, transthoracic echo elements, and the conclusions. Phase 2, this is where we are now, building the data elements for stress echocardiography and later working on transesophageal echo. We are expanding the number of participants in this registry. In a phase 3, we will look at some pediatrics labs joining the registry, could be looking at specific diseases within the congenital heart disease or specific situations as the use of chemotherapy in children who need these treatments. Futuristic looks, linking it to the outcomes, incorporation of images as we spoke briefly, and then looking at opportunities for technology expansion. A key goal of the Image Guide Echo Registry is quality improvement. And so one can compare quality against echo-specific peer-established benchmarks. You can view your individual performance against other members in your institution as well against national aggregates. You can identify where there are opportunities for improvement, implement changes, and then track the effect of the changes that you did on how that metric is now performing. You can see how your lab is aligning with ASE guidelines. And certainly the echo data will stay in the hands of the physicians who are generating these data. Some examples I have on this slide, for example, how many transthoracic studies in a given lab are read by an echocardiography MBE board certified physician. Or is this a lab that is accredited or not? What is the contrast use, qualifying it by study quality? Percentages of transthoracic echo studies who were deemed suboptimal by the physician reading the study, and did these get contrast or not? And then how comprehensive the measurements or the assessment is for a particular condition, for example, aortic stenosis. Is there a complete data set, or the physician just said severe aortic stenosis and has a velocity and gradient but no area, without a justification for why an area was not included? I will not dwell on MIPS, you've heard a lot about it, nor on the negative payment adjustments. This is a real-time feedback that shows for each physician where he or she stands. So there is the national benchmark, which is the vertical line. And if a given metric, be it accepted as a performance measure or not, is met, it will appear in green. If I'm very close to that one, it will show in yellow. If I'm way behind and I need improvement, it will appear in red. And you can queue this for as many measures that you want. You can limit it to performance measures that are accepted by CMS or to other topics that you want to look at from the data that is gathered. This is an example of how to track quality over time. And so we are looking at a physician who is trying to see whether his or her transthoracic studies were meeting appropriate use criteria. So when that individual started, they were not performing that well, and we can see that they are improving. This is an actual example from the Image Guide Nuclear, looking at looking at nuclear imaging in patients in the peri-op setting who were deemed low risk. So this is a situation where performing the stress test is inappropriate. So that physician started at a 67%, or that situation started with a 67%. This is for the registry in general, not just a particular physician. And as more labs joined with variable backgrounds, if you would, some less compulsive than others in dealing with these requests, the number went up. And then as physicians started recognizing the problem and implementing plans to improve it, the number of these inappropriate or rarely appropriate indications went down, and eventually this is where they stand. So typically there is a curve that is seen. Perhaps the more enthusiastic, more, if you would, people who are comfortable with the AUC and applying them join. And then as those who are less experienced join, you see some rise in that. And then as plans are devised and implemented, you see an improvement. So with that, I'll stop and we'll get questions.
Thank you, Sharif.
All right, we have a few questions up here. Please continue to send those into the system as well. Let's do the first question for Jeff. Here comes a good one for you. We can't not do the ordered test, even if obviously inappropriate, if the ED doc or neurologist insists. We can control our own ordering, but not the ordering of others. What do you think about that?
So it's very difficult to stop the train in real time, right? So you're in the lab and the study comes in. It's going to be next to impossible to stop it. You've got to get upstream. You have to engage the stakeholders. You've got to sit down with the service line leaders for neurology. This is our stroke protocol. We're not doing bubble studies in 90-year-olds, period. We're not doing that. And then this way, when the study order comes in, it can be auto-canceled. But it has to be, the legwork has to be done up front, and you've got to engage the stakeholders. Because otherwise, you're just the bad person on the back end, and that never works. That puts you in a vulnerable position, a bad position. It's got to be built with protocols up front around common conditions that we see every day.
So, Mike, you have that poster on the trigger in the Epic ordering system. How easy was that to actually integrate into Epic? What kind of hoops did you have to jump through?
Well, credit to Adam and Bethany Austin, who's the senior author on that particular abstract, for that idea and putting that together. It was actually fairly easy working together with the Epic folks. There's the ability to do all kinds of things like this, these best practice alerts in Epic, these kind of messages that will come up and allow people to perhaps change their behavior. And I think also in response to that question, it's true, if somebody asks us to do a test, we need to do it. Oftentimes, though, we find people haven't even looked in the medical record to see if an echo has been performed. It's easier to order an echo than a CBC. In fact, sometimes the echo is the first diagnostic test that comes up in the results section in our hospital. So I think these types of tools can help and gradually change behavior.
Our next question is for Dr. Naga. What are the local HIPAA regulatory implications that we need to consider when we think about joining the registry?
So there are specific agreements that the registry has developed, and institutions, legal teams will review them. There are no serious HIPAA issues that would be there in terms of violations or concerns. Obviously, the data, we're not talking about images, we're just talking about the reports. So these will be, some information about a particular patient will be needed so that the report can be linked to their demographics and to, from that, determine other things.
So we don't have to blank out the protected patient information when we send these things?
No.
Good. How about a question for Kathy? Will the use of quality-based programs allow for increased reimbursement? And who or what defines those quality-based programs?
Well, I think the days of us being incented to define quality programs is over. I think we had that with PQRS when they actually paid us to participate. Now I think it's on the other side of that coin, is that we actually will get penalized if we do not participate. So I think that's the key. The second part of that question is critical. There was a national consortium that was put together last year between Medicare and the private payers to equalize these quality metrics, so we don't have 1,000 different numerators and denominators and definitions of what these are. Unfortunately, that didn't happen. They've just regrouped again in Washington. They had their first meeting about a week ago. To me, that's one of the really key elements, is that we don't all have our own definitions of what ACEs and ARBs and different mechanisms for the numerators and denominators, but I think we're still a fairly long way off as it relates to that. However, you notice that ASC and ASNC have devised, and they report those to CMS and they get accepted. That's that QCDR mechanism that you can use to report your metrics. So that is a way to start, is doing it through the QCDRs.
We have another question here that sort of relates actually to all three of the talks, specific to ECHO and quality measures. Will there be a mechanism to evaluate when standard measurements on ECHO aren't captured, and will this impact reimbursement? So I guess it gets to, are there key components that should be on every ECHO report, and will that be tracked as a quality measure?
So the question is, what will be tracked as a quality measure?
I think the question is they want consistency in the measurements that are collected like we do for accreditation. Is that sort of what the question is? And I'll just take the payment part of that. I think it's going to be expected. But remember, the only way we can get paid for things is by claims-based data. Right now, trying to get stuff out of our EMRs, if you're not doing things in structured report writing, which we heard in the earlier session, structured report writing is a mandate if we're going to keep moving forward, because we have to be able to get this data out of our EMRs. So there's no way they can pay us unless it's in a structured field that is part of that billing cycle. And I'll let the clinicians answer the other part.
So before Sharif jumps in, the issue will come up at some point about mandatory accreditation from somebody somewhere, so IC, or if there's other entrants in the market, because there's going to have to be an external referee about quality, right? So people are paying for this. There's going to need to be some referee that says what you're doing is actually of quality. Now, it may be that there's other ways to do that, and perhaps even participating in the registry may be a proxy for that, and that may be a strategy. But I think as we go forward, you're going to see greater and greater scrutiny from the payers.
So in terms of looking at what quality measures one seeks, there is the quality measures that would allow me to get points that count towards the performance measures that are approved by CMS and then with the MIPS requirements, but also each lab can have their own quality settings that they want. Could be the report turnaround time, could be the use of contrast in certain populations, could be the thoroughness of evaluation of a valvular lesion. All of these could be set and could be tracked for each physician, and he or she becomes aware of where they stand and where they perform.
Great. So I think, do we have another question?
There's a few more. Yeah, they're coming in. Okay. One was a question actually for me. Can we share our best practice alert? We're happy to do that. Just talk to Dr. Fletter and myself after the session today, and we'll share that. Another question for Sharif said on your last slide, nuke AUC, rarely appropriate, fell to 0%. Does the image guide registry explain why it fell, and what were the details of those changes that were made?
So the last slide was showing an indication where it is rarely appropriate to do a stress nuclear test. So as the physicians got that finding or that report from the registry saying your performance, you're having so many studies that are qualifying as rarely appropriate, they recognized that, they took steps to improve that situation, and as a result, they ended up with no studies falling into the category of rarely appropriate, that particular setting, peri-op low risk. So
Okay,
this is an example of how the registry allowed someone to change their situation and end up earning points, if you would, for a performance measure, and also translated to the cost savings that Jeff talked about.
So you've probably noticed in the program throughout the meeting, we've got specific experts on the registry having sessions, and I would encourage you to come and meet with some of them, because obviously everyone's got a lot of questions about this, and I think they can answer it. We've got really 2 or 3 minutes, and I'd like to give each of the panelists 45 seconds. So you got 3 nouns and 2 verbs to just tell us what's your take-home message from the morning. Jeff, you start.
I'll start. Quality, value, accountability, systemness, process. These are things that have to be not extra work, these have to be the work, right? Because we've been, able to avoid this. Healthcare is impenetrable in terms of the outside looking in terms of what true quality is. But on the inside, we know what it is, and we have to start moving our systems away from the inertia of doing the way we've done it before towards those particular values.
Kathy?
I know you'll find this surprising. Data, understanding your data, the combination of finance and quality coming together, and having a physician-led organization that moves us out of this fee-for-service while you're battling with your CFOs, because they're still all about volume. So I think it's critical for you to own your data, and of course you're going to leave here documenting and making sure that you never use an unspecified code.
And remember the 3 homework pieces that she gave us.
Let me do them again. So you're going to find your QRUR. You're never going to use an unspecified code again, and you're going to make sure your billing system is open so you can accept 4 to 6 diagnoses per visit.
Great. Sharif?
Avoid the diagnosis, I guess, of essential hypertension and hyperlipidemia if you can help it. But if that's what you get, I don't know what else to do. Look at the registry seriously. It's free for ASE members. It will allow you to participate in a qualified clinical data registry that will earn you points. It's free, as I said, for ASE members. It has a potential beyond just that piece of it for each lab to use it for their QA, their own internal QA device plans that meet also IAC requirements for QA. And we are open for comments and suggestions. Visit our booth. There are demonstrations. You can look at what the interaction is like with the registry interface, and we'll welcome your interest and your comments and suggestions.
Excellent. Thanks to all the speakers this morning, both in this session and the previous. Again, the talks will be available on the website within the next few days. Thanks, everyone.